lung cancer is the beast of all the cancers out there. It is the one that you guys need to know because there are so many patients that will be affected by this. So I'm going to try and cover a number of things today to try and give you from diagnosis, staging, and treatment. We'll give you the statistics about lung cancer. We'll show you some things that might be a little bit more optimistic about it. Talk about some of the diagnostic ways we can get this thing staged. Also show you some histology. Talk about the treatments and how they've evolved in the past 3 years. And then quickly a solitary nodule conversation. And then should we be doing lung cancer screening? So I'm going to do this at a couple of questions, see if you can get these right. Which of the following statements about lung cancer in the United States is correct? There are more new cases of lung cancer each year than breast or prostate. Survival of patients diagnosed with lung cancer has significantly decreased since 2018. There is many cancer deaths each year from lung cancer as there are from colorectal, breast, and prostate combined. Those are the next 3 biggest cancers. More women die from breast cancer than lung cancer. Anybody want to venture up which one of those is correct? And the answer is there are as many deaths each year from lung cancer, colorectal, breast, and prostate. This is a crazy statistic. It is the most common cause of cancer death in the United States. The overall 5-year survival has improved in the past 3 years. It's gone from 15% to 18%. That is a monumental improvement as the survival for lung cancer was stable for 40 years and did not change. The total number of deaths by lung cancer equals the next 3 most common cancers combined, colorectal, breast, and prostate. If you look at 2021, these are the expected numbers you'll see of cancer deaths. You can see how many lung cancer there are in relationship to the others. These other cancers generally have better treatments that work better. And you can see that in 2021, we're looking at having 235,000 new cases in the United States, and half these people are going to die. There are multiple risk factors which they're going to test you about on boards. They're going to talk to you about gender. They're going to talk to you about smoking history, older age. Even the presence of airflow obstruction on your PFTs is a risk factor for lung cancer. There must be a genetic predisposition, right? Because some people smoke their brains out, and at age 95, they still don't have lung cancer. And there's a number of occupational exposures that predispose you to developing lung cancer. And I'll just throw out one other comment. The average age of a patient with lung cancer is 74. 74. In 2021, congratulations, women. You have finally caught up. This is a disease that is both equal men and women now. It didn't used to be that way. This is the male cancer deaths from back in the early 1930s. And I want you to watch that red line. The red line is lung cancer and how it skyrockets into the 1990s. And the reason this started was back in World War I, we started giving out cigarettes to people on the front lines. And as a result of their addiction, they started getting lung cancer 20 years later. We did the same thing in the subsequent wars. And by 1940s, we were well on our way to having lung cancer surpass all the other cancer deaths for men. Women were a little bit delayed. We didn't allow women to smoke until they had women's lib in the 1960s. And guess what happened? We found out that it was sexy to be skinny, and we found out cigarettes make you lose weight. When you put those together with a marketing campaign, you end up with cigarettes being distributed to women. And sure enough, right after that, you start seeing the rise in lung cancer deaths. And here it is, breaking past breast cancer and the leading cause of cancer death in the United States by the late 1980s. Here's a nice graph for you. Here's tobacco consumption, and here's the cancer death rates. And as you see, cigarettes, it's about a 20 or 30 year delay, and then you start seeing the rise in cancer deaths, and here's the women right behind there. We know that most patients develop lung cancer has smoking as a predisposing factor. There are some that are secondhand smoke. We also know there's a rising number of people who are presenting now who are never smokers. Asian female, never smoker with adenocarcinoma, EGFR positive. You'll see more of those coming down the road now. Lung cancer has a lot of patients attributed to smoking, but only 20% of smokers will develop lung cancer in their lifetime. And the question is always, why doesn't everybody get it? And it's because some get heart disease, some get emphysema, some have a genetic predisposition. There must be. We know that your risk decreases when you stop smoking, but it never goes back to zero. It's not like heart disease. It's the total number of cigarettes that you smoke. 50% of our new cases are former smokers. So your risk does not stop when you stop smoking. It just stops increasing the risk. When you look at other causes, the second thing to look at is radon. Radon is a gas you find in the basements of most of the people in the mid-Atlantic. When you sell a house, you have to prove that radon's not in your basement, and the reason is it causes lung cancer. The other thing on the list we'll talk about is asbestos, because there's interesting relationship there and a bunch of lawyers that care about this. And the third one that you should think about is in our medical population, patients who've received radiation previously have a risk of developing lung cancer, sometimes right in the area where they were treated. Asbestos has this known association with lung cancer that magnifies your risk of developing lung cancer. We know that there are certain fibers of asbestos that are more angry than others. And if you remember crocodiles, they are more angry than the other types of fibers that are out there. The peak incidence is many years after their exposure, 15 to 24 years after they get exposed to these things. So you really need to get a good occupational history from people. And the thing that's interesting about asbestos exposure is it magnifies your risk. If you're a non-smoking asbestos worker, you have a 5-fold higher chance of developing lung cancer. If you're a smoker, some estimates say a 10-fold higher developing lung cancer. But if you're a smoker and have asbestos working, it's up to 50 times higher chance of developing lung cancer. The most important intervention you can do for a patient who has asbestos exposure is get them to stop smoking. This is an oldie but goodie slide. There's very few slides out there on how many cigarette packs and your relative risk of developing lung cancer. And we do know that the more you smoke per day, there's a rising, increasing relative risk of developing lung cancer. If you're a cigar smoker, when you go down and play your golf round and put a cigar in your mouth, that's completely fine, right? You don't inhale it. 3-fold higher chance of developing lung cancer. Pipe smokers, they're right, they don't inhale it. It only goes in their mouth. 8-fold higher chance of developing lung cancer. If you are a relative of somebody, you have a higher risk of developing lung cancer. We talked about asbestos magnifying your risk. Uranium miners also. Now you say, well, there are no uranium miners around DC, but in Southwest Virginia in the past 2 years, they've been talking about opening up a uranium mine. So yes, that is a magnifying type of problem. So we know that lung cancer shows up at some point with symptoms. They may be symptoms directly from the tumor. It may be because the tumor is invading other structures, causing a classic is hoarseness of voice from paralyzed vocal cord. You can get SVC syndrome. You can get disease from the metastatic lesions that they had. And obviously, the classic patient comes in with anorexia and weight loss. Paraneoplastic syndromes, I have a slide on that, and we'll go over those. So patients don't present with symptoms until they have advanced lung cancer. And that is the theme of today, is to see if we can change that. So here's question number 2. 65-year-old male comes in with fevers, chills, has productive cough, has a little bit coughing up blood. Chest x-ray is shown here. What diagnostic test do you order next? Here's our chest x-ray. You can see there's probably a mass somewhere hidden here in the right hilum. There's loss of volume in the right upper lobe, so some tenting of the diaphragm. The fissure is way up here, and you see all this consolidation going on. So what tests are we doing next? CAT scan, sputum cytology, bronchoscopy, CT-guided needle biopsy, or surgical resection? Anthony Rowe, you're in charge. What would you do?
A would give you the best.
Yeah, I think everyone's going to agree that you need a CAT scan of chest. Let's remember the following word, though: with IV contrast. okay? This is not a non-contrast CT scan. It's a contrast CT scan. There's some things you're going to find on CT. You're going to find out that a nodule is less than 3 centimeters and a mass is more than 3 centimeters. So let's start using the right terms. Masses are not 1.0 centimeter. Those are nodules. Right? So if you find something in the periphery, it's an adenocarcinoma more likely. Not always, but mostly. If it's a central tumor, you might be more likely to find squamous cell cancer. And obviously, the most important thing about the CAT scan, it gives you details about a nodule if you find it. Does it look like it's malignant? It tells you about the extent of disease. Is it extending into the mediastinum, invading into great vessels? And probably one of the most important things the CAT scan of the chest is going to do is evaluation for lymph nodes. Lymph nodes decide everything for lung cancer. We do a standard CAT scan to include the upper abdomen to make sure there's no metastatic lesions in the liver and adrenal glands. Bronchoscopy is something you're going to see a lot of cool things happen. We can evaluate things that are inside the airway. We can do biopsies of things in the airway, obviously. And what's really fun now is we are one of the first sites in the world to have a robot bronchoscope. That robot bronchoscope allows us to go out to the periphery to biopsy small nodules. The number of small nodules today is number 100. We've only had it for 5 months and we are cranking these cases out. We're able to biopsy nodules that are as small as around 7 or 8 millimeters. And that is a major advance in technology. So not only can we stage the mediastinum, but we can also get the peripheral lung biopsy. Staging the mediastinum by bronchoscopy is critical. It allows us to sample those lymph nodes that are beside the airways. It allows us to decide whether the patient's going to be operable or not. If they have contralateral lymph nodes, they're going to be inoperable. It is minimal risk to the patient to do this and has replaced mediastinoscopy as the gold standard, really. We'd put CT-guided biopsies up there. When do we do a CT-guided biopsy of a lung nodule at this point? I still see 80% of referring doctors send me a patient with a 5 centimeter mass, and their first thing they did was a CT-guided biopsy. I don't do CT-guided biopsies on patients. It does not give us what we really need to know, which is definitive staging of the mediastinum. When would we use it? Well, if there was a person who is inoperable and maybe we're considering this is metastatic disease from someplace else, or maybe we think this is not going to be cancer, then we might consider somebody for a CT-guided biopsy. But you have to remember, if you miss it, it doesn't help us. And even if you biopsy and prove it's cancer, then you're going to send them to me, and guess what I'm going to do anyway? Sample the lymph nodes with bronchoscopy. So you need to remember that CT-guided biopsy is not something that we just jump to initially. Here's an example. 65-year-old male comes in with history of smoking. He has this nice little lung nodule, and we see lymph nodes hiding on both sides of this contrast CT scan, including one on the contralateral side. Question is, which test do we order next? The boards are going to love to tell you which do you order next. They don't care if you know all of the answers are good. They're going to say, which do you do next? CT-guided biopsy, which I just told you was not a great idea. Video-assisted thoracic surgery and possible lobectomy if it's cancer. Well, that might not be such a great idea if there's lymph nodes involved on the other side. PET scan, PFTs, CT scan of the head. And the answer we're going to choose is PET scan. So when we did the PET scan of this patient, I actually cheated a little bit by giving you just a little piece of that nodule there. But there were multiple contralateral lung nodules in addition to the mass. PET scan is a critical part of staging for lung cancer. It can detect lesions down to 8 millimeters, 90% sensitive and 85% specific. That means we miss 10% of the cancers and we call it cancer 10 to 15% of the time when it's not. So this is good for evaluation of a solitary pulmonary nodule, but not enough by itself. Mostly we do it for staging to make sure that we do not miss anything. We want to make sure we don't have any surprises. If somebody shows up with a PET scan with liver mets, they do not need a bronchoscopy. They need a liver biopsy. Here's an example, 85-year-old had emphysema, had a previous left-sided lobectomy for stage 1 cancer. And you can see they have an irregular rounded nodule, maybe even a little cavitation in that thing in the left remaining lung. And we can see here on the PET scan, the benefit of PET is it is going to check out from your jaw down to your mid-thigh to make sure there's no other spots. And in addition, it gives you feedback about that nodule. That nodule is hot. That nodule is likely going to be cancer. If they ever put down on the boards that you should have a mediastinoscopy as one of the choices, mediastinoscopy was always the gold standard for sampling lymph nodes, but it has been replaced with endobronchial ultrasound. We now spend, we probably do 350 EBUS cases a year here at Georgetown. And the last time we did a mediastinoscopy was like 3 years ago. So give you an idea that this has replaced the gold standard. Here's the histologies. We know that lung cancer comes in lots of varieties: non-small cell lung cancer and small cell lung cancer. Small cell lung cancer is becoming less common. It's only about 20 or 25% of our tumors that we see. Of the non-small cell, adenocarcinoma is the #1 and rising. Squamous and a few large cells, and then adenocarcinoma in situ is the yellow one you see. So let's talk about adenocarcinoma. It is the most common one that we're seeing. It's usually peripheral, typically has all these glandular cells that you see producing mucin, and adenocarcinoma has 10 subtypes. From the most solid adenocarcinoma to adenocarcinoma in situ, and a varying degree in between. Adenocarcinoma in situs are the classic, looks like pneumonia. It has tumor cells that line the alveolar spaces. So that's why it looks like pneumonia, because you still have air going through the area. These are typically ground glass opacities that we see on CT scan. The good news about these are that they are less aggressive. They spread through the airways instead of through the lymphatics and bloodstream usually. And they, because they're less aggressive, they don't grow as fast. They generally don't kill people as aggressively as adenocarcinoma. There is a definite progression though. As these get bigger, they may start forming some solid parts of adenocarcinoma. So that's why there's 10 subtypes, and it really comes down to like how much is solid adenocarcinoma and how much is the kind that is adenocarcinoma in situ spreading along the airways. Squamous cell cancer is the typical one that cavitates. It's usually more centrally located. They have this intravascular invasion and intracellular bridging, and then they do keratinization. And if you get a board question, they'll love to give you this. It'll be a perfect squamous cell keratin pearl with cells rounded like that. That's the classic picture for squamous cell. Large cell carcinomas are really poorly differentiated. They have bizarre looking tissue. You can see they have they have lots of cytoplasm. They have large nuclei with lots of nucleoli in there. You see all these cells with multiple nucleoli. In the diagnosis and treatment, we need to have a big attention to this one thing, which is millimeters matter. If your tumor is less than 1 centimeter and we treat you for non-small cell lung cancer, you have a 91% cure rate. I told you earlier that 18% is what everyone averages. That's because we don't get these patients up to 1 centimeter and we don't get them diagnosed that early. 1.1 to 2 centimeters, 86%. 2.1 to 3 centimeters, 81%. You see the drop off in survival with millimeters change. This is a critical thing to acknowledge, that unless we pick up tumors when they're very small, we have less chance of cure. So staging a lung cancer for non-small cell is complex. A T1 is anything that's a nodule, less than 3 centimeters. And if it's less than 1 centimeter, the smallest there is a T1A. If it's 1 to 2, it's a T1B. And if it's T1C, if it's 2 to 3 centimeters. T2s are patients whose tumors are more than 3 centimeters. They may invade into the visceral pleura or cause atelectasis, but they do not invade the main carina. And a T2A is 3 to 4 centimeters. T2B is 4 to 5 centimeters. A T3 is any size, but it starts invading into stuff like the mediastinum or the chest wall. It cannot get into anything bad like great vessels or vertebral bodies or brachial plexus. If your tumor is 5 to 7 centimeters, that also makes you a T3. If you have a satellite nodule in the same lobe, that means you have adenocarcinoma in the right upper lobe and you have a smaller spot of adenocarcinoma also in the right upper lobe, then that is a T3. If it involves the phrenic nerve or the pericardium because of improved surgical techniques, it can be a T3. A Pancose tumor is one that shows up at the top of the chest, and those also can be treated aggressively with a little better survival, so they are T3. T4s are any size, but they get into bad things. So if you have a size greater than 7 centimeters, you're also a T4. If you have a satellite nodule in a different lobe, but on the same side of the chest, that's a T4 also. And if it involves a recurrent laryngeal nerve or diaphragm, or it's a Pancose tumor that gets into the nerves or the vessels or into a bone, then obviously those are bad things. That would also be a T4. The nodal staging has been stable for years now. It's not about how many nodes. It's about, do you have one in the location closest to the tumor? So if you have a right-sided tumor and you have a right hilar lymph node, that's an N1. If you have a lymph node in the mediastinum on the right paratracheal side and you have a right upper tumor, that is N2. Subcarinal tumors, that's the one between the right and the left, those are always N2 regardless of what side this is on. And N3 is anything on the contralateral side. So when you think about the metastatic staging, M1A means there's malignant pleural effusion or you have a cancer nodule with the same cancer on the contralateral side. An M1B means you have a single metastatic lesion outside the chest. And an M1C means you have multiple mets somewhere else. We know there is a difference in metastatic disease. If you have somebody who has just a single lesion outside the chest, that does much better than you see the green line, which is somebody has multiple mets. And that survival curve is much worse. So these two, M1A and M1B, because their survival is similar, they've grouped them together to make those a stage 4A. So here are the stages that were all new to us when we had these new cards come out. We made a new stage, 1A1, 1A2, and 1A3. And we did this because it reflects the survival of these patients. There's a dramatic difference between a 1A1 survival of 91% and a 1A3 is 70 to 80%. There's a new category now, stage 3C. These are patients who have contralateral nodes and also have big tumors, and that was done because it reflects the worst prognosis of these patients. And the stage 4 has been broken into stage 4A, which is a single metastatic lesion or a malignant pleural effusion, versus the patient that has multiple mets located anywhere, makes them a stage 4B. Which means, of course, we have new staging cards. And if any of you'd like a new staging card, I have them in my desk. It costs you a visit to say hi. Come by 4 Main, I'll give you one of those staging cards for you. We do know that staging is critical, right? If you just look at the 5-year survival, as soon as you get to stage 2, your drop-off is huge. You get to stage 3, we're talking a 20 or 30% survival, and stage 4 are the patients that don't live very long. So let's talk about the other side. These are the patients who have small cell lung cancer, and neuroendocrine lung tumors run on a spectrum from small cell lung cancer being the most aggressive to atypical carcinoid to typical carcinoid, which is almost a completely benign disease. Small cell lung cancer is the most aggressive lung cancer there is. It's an interesting term to call it small cell because it's not small. And you see these gigantic nucleus everywhere. But what do you not see? There is no cytoplasm. So when we say small cell lung cancer, we're talking about no cytoplasm. That's where the name came from. So they are giant cells. The tumors are typically centrally located. We generally do not see a peripheral lung nodule. That's very uncommon to see a lung nodule. If you see a lung nodule, it's almost always non-small cell lung cancer. Small cell lung cancer is associated with smoking. We generally do not see this in non-smokers. And unfortunately, most people show up with bulky lymph nodes and metastatic disease on presentation. So there is this fine chromatin pattern. If you see all blue all the way across your screen, you can tell there's lots of mitotic action happening here. There is this tendency to smudge when they do this stains on this. And these two stains, synaptophysin and chromogranin, are used by the pathologist to confirm that this is a neuroendocrine tumor. Carcinoids are interesting. A typical carcinoid is usually an endobronchial nodule that's blocking an airway presenting as pneumonia. Surgical cure is a high survival rate with this, and this can happen in never smokers. Now, there are a few times we'll see atypical carcinoids, and these you can tell the cells look a little bit more angry. There's more mitotic features happening in here, and it's more aggressive, and sometimes these require chemotherapy after the surgery. So small cell lung cancer is very simple to stage. It's either limited or extensive. Limited stage means that we can fit it within a radiation field. And extensive means we can't do that. Now, you cannot radiate the entire patient's body. You can only radiate a portion of the patient. Unfortunately, most patients present with extensive stage, and that is more aggressive. And you can see the survival of small cell lung cancer is very poor. There's less than a 10% survival here after 5 years for a limited stage small cell. So why the poor prognosis on these cancers? Well, it's all about patients showing up with advanced disease at the time of diagnosis. If you wait till a patient's symptomatic, they're already stage 3A or 4, that is too late for having a good, meaningful long-term survival. And unfortunately, we get very few patients who are early stage cancer if we wait for them to have symptoms. And only 20% of these patients are going to show up as stage 1. So successful surgical cure is only possible at early stage. So let's jump to treatments. 60-year-old smoker has a 4.1 centimeter solitary adenocarcinoma, and there must be some reason why the doctor put 4.1 on this measurement. What is the best option for treatment and survival? Well, let's play the boards correctly. The boards are going to write down a bunch of numbers, a bunch of letters. They're going to say, well, here's lobectomy, 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 lobectomy. Why would you pick wedge resection? I think the answer to that is, let's play the game well. We're going to play the one that has the most options. So lobectomy is true. When you take out the whole lobe, we have a much better surgical outcome than having a wedge resection where cancer has a better chance of coming back near the staple line. So the question on this is really about, is it surgery alone, or should we add chemo, radiation, or both to the thing? So you're thinking about that, and you're wondering, well, if I put 4.1 centimeter, there must be some data about that. And the answer is, if you have a tumor that's 4.1 centimeters, you need to be meeting a medical oncologist to talk about drugs. That means only stage 1 lung cancers are patients who are having surgery alone. If you're a stage 2 or higher, you are being considered for drugs. So stage 1, lobectomy is a treatment of choice. We know that if you get it out, there's less chance of it coming back. We know that if you are inoperable, regular radiation does poorly with only a 10% cure. However, with the advent of Cyberknife, which we first got in 2004, we've now treated more patients in the world with Cyberknife than any other setting for lung cancer. Why do we do that? Because we have so many patients who are inoperable because of bad emphysema or heart disease, and SBRT treatments for a solitary nodule have a very high cure rate. That is one that approaches the survival of surgery. We have a local control rate around 90%, and you heard that number before when we talked about surgical treatment of stage 1 cancers. RFA is an option, but unfortunately has a higher frequency of local ablation, causing only a partial killing, and unfortunately tumors recur right where the treatment was in about 40% of the patients. So stage 2 patients require surgery, but now they should be given drug therapy after surgery. There may even be a role in some patients for radiation. Stage 3 cancers are never going to be tested for you because there is some controversy and the boards can't give you controversial questions. But we should answer this with, you need a multimodality approach to treatment. It should include drugs for sure. It should include radiation, and it may include surgery. There is good data, and we follow this data, that you could do neoadjuvant drugs first, then surgical resection, and probably put you on immunotherapy afterwards. Stage 4, you notice the word, it says drug therapy and does not say chemotherapy. The days of chemotherapy are numbered. There are some times when we cannot do surgery. It's when patients are stage 3B or 4. That means that if they have disease on the contralateral sides or they have it invading into bad things. The other thing that makes us not be able to do surgery is if they are inoperable. So there's unresectable and there is inoperable. How do you decide somebody's inoperable? You get a lot of these consults if you're a pulmonologist. It's like, when am I going to be able to send this patient to the OR or not? And if they're medically unfit, if they had a very bad heart function, and to choose if they have very bad emphysema, you can do the following. You can check out their pre-op FEV1 and DLCO and calculate how much lung function is going to be removed to see if they're going to be left over with enough so that their FEV1 is greater than 40% or DLCO is greater than 40%. If it's less than those two numbers, they're going to fall in the inoperable category. We can do a pulmonary exercise test. We hook them up to a bicycle, we make them breathe into a machine, and we can calculate when their VO2 max is. If their VO2 max, their maximum oxygen consumption, is less than 10, they are inoperable. If it's more than 15, they can have a lobectomy. If it's more than 20, they can have a pneumonectomy. An even simpler test is to take somebody in the stairwell, and if they can walk up 3 flights of stairs, they can be operable for a lobectomy. If they can make it up 5 flights, they can have a pneumonectomy. So let's talk about drugs. Chemotherapy drugs are effective for lung cancer. In non-small cell lung cancer, it's important that you do at least a 2-drug chemotherapy regimen if you're going to use it. One of them has to be a platinum drug, and the other can be any of the following: Taxol, Taxotere, gemcitabine, or etoposide. Small cell lung cancer is so responsive to chemotherapy that everyone uses the same regimen because it works so well. Cisplatin and etoposide, there are no choices there. The only thing that I would add is that everybody with small cells should also be considered for immunotherapy. Let's talk about biological agents, because now it's not just about chemotherapy. You can talk about Avastin, which is an anti-angiogenesis drug. Chemo adds an effect to having Avastin on here. It turns out that some cancers have extra blood vessels being formed, and this drug tries to shut that down. There is an increased bleeding risk, so it is contraindicated in those central squamous cell cancers. We don't use Avastin as often as we are using the other biological agents. Erlotinib was one of the first of several drugs that's an epidermal growth factor inhibitor. It can be used as a primary drug in these patients. The classic person who has this genetic mutation is Asian, never smoking, female, and has adenocarcinoma in situ. It is an oral drug. The other things that have epidermal growth factor are skin and GI tract, and guess what? They get rash and diarrhea for a pill. These drugs are very effective, and if your patient has those 4 characteristics, there's a chance, a 40% chance that they may have this genetic mutation on their cancer cell. If they have none of those factors, say they're Caucasian, male, smoker with squamous cell, they still may have the defect, but it's less than 5% chance that they have this type of mutation. So everything about diagnosing lung cancer now is staging and then finding out, do they have a molecular targetable, molecular target that we can go after. There are two drugs called crizotinib and alectinib. These are for patients who have an ALK positive gene tumor mutation. And they are very effective. If you end up having an ALK positive mutation, great things can happen for you with these type of drugs. Let me show you an example. This is a patient who came from Africa, did not have anybody in the US he knew. He went to New York, he got admitted. He had this large mass that you can see fills up his entire right chest. They did a mediastinoscopy. His nodes were negative. They couldn't believe it. He got a note that said, go to Georgetown in Washington, D.C. So he got on a train after his week-long hospitalization in New York City, got on a train, took his little note that said Georgetown and went to George Washington, where he was admitted to the hospital. They did a repeat mediastinoscopy because they could not believe this huge tumor did not have mediastinal involvement. And again, the lymph nodes were negative, did not have cancer in them. And this is an ALK positive adenocarcinoma. They saw the little note. Somehow they gave him DC Medicaid, which then made him now have insurance. They discharged him and followed up at Georgetown Outpatient Clinic, where we saw him and we gave him crizotinib, and he got that drug free from the drug company. This is his scan 2 months after initiating therapy with his oral drug with no side effects. A dramatic response. What's even more impressive is he was taken to the OR after 2 months, and when they removed that residual tissue, there were no viable cancer cells anywhere in his chest. A complete remission. Not saying that everybody gets this benefit, but times are changing for lung cancer. And if you have this type of mutation, this drug can be very effective. He then left DC and went back to Africa with quite a story. Biological agents are changing how we treat patients. Mutation testing is essential. It is part of what we do. We need to give them enough tissue that they can tell us which mutation the patient may have for their cancer. We now know of 100 mutations that can be tested for. There are at least 5 now that have a treatment. So if you have one of these mutations, you may have a drug that is specific to it and will work better than chemotherapy. The other thing that has revolutionized lung cancer in the past 3 years is the use of immunotherapy. If you watch the Super Bowl, you saw for the first time last year before the pandemic that there was commercials about lung cancer treatments. I'd never seen it in my lifetime. This is the first time. And why? Because treatment with immunotherapy to rev up your immune system to recognize cancer cells as foreign and kill them is a novel treatment that works fantastic. Turns out that there is more than one drug now that we have at least 3 approved for lung cancer that work through the mechanism of immunotherapy to treat lung cancer. It is first line for patients who have stage 4 disease, and although we can test for how much PD-L1 level you may have on your cancer cell, even patients who have a low or 0 amount may still respond to immunotherapy. We are using it also in patients who have definitive treatment for stage 3 disease. If they've had their chemoradiation, they get put on immunotherapy afterwards as sort of a maintenance drug. We know that strategy, at least for a year or longer, has increased survival. How much better has this made things happen? Well, because of immunotherapy, the overall cancer survival for the United States just improved by 2% in 2 years. And the reason was the improvement in survival of patients who have lung cancer and on immunotherapy. This is changing some of our metastatic disease with lung cancer into potentially a chronic disease. This is fascinating. If you are a responder to immunotherapy, you may be kept on immunotherapy once a month, potentially for the rest of your life, with a potential side effects of having immunotherapy-related diseases, such as pneumonitis and bowel colitis and things like that. But you may be actually cured of your disease, or at least put into a disease state where it's not active. Small cell lung cancer is a little bit different. We know that chemotherapy is very effective. If you are a limited stage lung cancer, small cell lung cancer patient, you're going to get chemotherapy with concurrent radiation. If you have extensive stage, we just give you chemotherapy. However, immunotherapy has been shown to improve survival with small cell lung cancer. That article by Steve Liu here at Georgetown Hospital, New England Journal 3 years ago, means that everyone who gets the 2 standard drugs of chemotherapy should also be considered for immunotherapy as part of their regimen to give them longer chance of survival. In patients who have small cell lung cancer, the drugs definitely don't cross the blood-brain barrier very much. So we give them prophylactic radiation to their brain. Why do we do that? Because if you don't, small cell lung cancer loves to go to the brain, and it will cause metastatic disease to form if you don't. So in limited stage, you cure them, you put them in remission, then they get whole brain irradiation. Obviously, we treat patients who have metastatic disease in the brain with radiation as well. Interesting note that patients who get multiple non-small cell mets in the brain are typically being treated with Cyberknife and not being treated with whole brain irradiation anymore, because those focal lesions can be better treated with single fractions of radiation with Cyberknife, and it doesn't cause as much debilitating memory loss and other side effects of whole brain radiation. But for small cell lung cancer, it's whole brain radiation. All right, let's go to question 5. 60 years old, smoker, comes in without symptoms, has a routine x-ray. What do you order next? And it's a little dark, but I think I see a little calcified, maybe something nodule up here in the right upper lobe, maybe a little granuloma right there too. Do we do a CAT scan? Do we do a CT guided biopsy? We're gonna look at some old x-rays. We're gonna do a PET scan. We're gonna just go take it out.
C.
The answer is always, let's look at everything. And one of the things you find in everyone using the computer is you may not be pulling up those old x-rays and looking at them yourself. You should. It's very important. Here's the old x-ray. And this one was from 6 years before. And guess what? That nodule has been there. It's completely unchanged. I didn't order it, but there was a CAT scan done, and that nodule is fully calcified. So most evaluations, solitary pulmonary nodule, we'll find the patients are asymptomatic. And the most common reason we see for nodules is fungus. Inhaled fungus. Histoplasmosis is endemic in the mid-Atlantic, but obviously very heavy throughout Minnesota and the Ohio River Basin. When we do lung cancer screening CT studies, we know that a lot of nodules are found during CT screening, and only 2% of those nodules turn out to be cancer. So you need to be able to figure out which ones are the cancer ones and which ones are not. If they have spiculations, they're irregular. If they have eccentric calcifications or they're bigger, they're more likely to be malignant. Here's a nice little picture of what looks like a malignant and what looks like a benign nodule. All calcified, central calcification, popcorn calcification, laminated calcifications. Those are all examples of benign patterns of solitary nodule. If you see stippling or you see eccentric calcifications, you should think this may be malignant. Here's the other slide that I think is important to recognize. I think all of us would say, if I looked at this nodule, spiculations, size, this looks like a lung cancer. How many people in the room are thinking this looks like a cancer? I would. This is an adenocarcinoma in situ. And this part solid one where it's ground glass with some solid transformation. Remember we talked about 10 subtypes of adenocarcinoma. Here it is. This is one that has ground glass with solid central part. This is somebody who's transforming to a more malignant process. So what do we do with these solitary nodules? Well, if they're new enlarging, they're getting bigger, we have to do something about them. If they stay stable for more than 2 years, they're likely benign. But those ground glass opacities, you better follow them for at least 5 years, if not longer, because sometimes they start changing into a more malignant process. If they're bigger than 8 millimeters, then we'll think about doing a PET scan. So LungRads is a nice system for following our lung nodules. And if your nodule is basically less than 6 millimeters, you don't need to do anything until the next year's scan. If it's 6 to 8, you do 6-month CT. And for those that are bigger than 8 millimeters, we need further evaluation. PET scan, 3-month follow-up at minimum. This should be like pulmonary consultation, okay? Because you have a lung RADS 4, you're talking about somebody that may have lung cancer. And I have a robot that can now biopsy things as small as 8 millimeters. This slide is important. If you remember nothing when you're walking into the boards, you should remember that they're going to show you a paraneoplastic syndrome. Why? Because it's fun. Do we see a lot of these? No. But because it's fun, they're going to put it on the boards. If you can't remember anything else, just write down small cell lung cancer. Okay, small cell for everything. If you can remember, hypercalcemia is squamous cell cancer, but small cell is the one that causes all these other paraneoplastic possibilities. All right, question 6, 55 years old, comes in with 30-pack year history of smoking, concerned about his risk for developing lung cancer. Which of the following screening tests is recommended? Annual chest x-ray, sputum cytology, spiral CT scan, flexible bronchoscopy, or is none recommended?
So it should be stop smoking and yearly CT.
Spiral CT scan. And I agree with your comment about stopping smoking. So the NCI in the 1970s proved that doing a chest x-ray on a yearly basis did not change mortality. These are the mortality of the 3 large institutions compared to controls. There was no difference. So screening should not be offered to general population. But they wrote in their last line of their New England Journal article, however, a chest x-ray may be a benefit in individual high-risk patient. I don't know why they added that, but it was not necessary. It certainly does not change survival. CT scans, we know, find early stage cancers. They find them in a large number of patients that you would not have thought would get them without symptoms. Here we have, 2/3 of the patients at Mayo Clinic had an incidental nodule found, though. And in New York City, 25%. And I'll tell you, at the Georgetown number, we're running about 60% of our lung cancer screening CT scans find a lung nodule. But only 2% are cancer. The other 98% need further follow-up. The National Lung Screening Trial was performed here at Georgetown. The interesting part I told you is that lung cancer average age is 74, and this study only went to age 74. They missed half the patients. They used a 30-pack year history of smoking. They randomized for chest x-ray, which is a placebo, versus spiral CT scan for 3 years in a row. And then they followed the patients. They wanted patients who were younger because they were afraid if they got over age 80, they couldn't operate on them. We have Cyberknife. We can treat people who are over age 80. We can do surgery on patients who are over age 80 in some patients if they're good quality of life. And we've treated patients with lung cancer with Cyberknife for up to age 95 or 96, and they did not die at age 100 of lung cancer. They died of other disease. What did we find? A 20% survival benefit. That is better than mammography. That is better than colorectal screening. That is better than prostate screening. We know this number has been repeated now in a Dutch study, and it found out an even higher number in women, 60% improvement in women's survival if they have CT scans done every year. U.S. Preventive Services Task Force has recommended this a category B, which means you should, as a good doctor, as an internist, be ordering this scan. It should be done on patients who are age, something's in yellow there. 2 weeks ago, they changed it. It used to be 55 to age 80. It's now age 50. It used to be 30-pack years. It's now 20. And you need to be a current smoker or quit within the past 15 years. It's estimated by lowering that number down on both those, it would include another 8 million US citizens to make a total of 14 to 16 million US residents who qualify for lung cancer screening today. You need to be sending your patients to us. We need to determine when patients have tumors that are this size and not waiting until they're this size. If they get to that big and they start crushing all the vessels and invading into the mediastinum, it's too late. I used to make fun of this. This is in the Washingtonian, that this virtual CT of your whole body could detect all these diseases. The results are stored in our database and compared to your local. This will allow you and your doctor to manage any disease in order to alter or reverse its course. I'm not sure we're quite there yet, but we certainly know that for lung cancer, we should be screening our patients. There are 50 million current smokers in the US and 50 million former smokers. That is a lot of people who are at high risk. Obviously, the only way it's going to be cut back is if people stop smoking and stop juuling, because juuling just makes you move over to cigarettes. Here's my summary of everything I just told you. Survival is due to advanced stage of presentation. Staging, review your own films. I don't believe anybody says on their outside interpretations, I want to see it myself. Biopsy the most advanced location. What does that mean? That means don't biopsy with a CT guided biopsy the 5-10 centimeter mass, whatever it's in the right lung. We need to find out where has it spread and biopsy that, because we need to be sure that the patient is not operable or is operable. When we talk about operable versus resectable, we need to make sure that the patient's post-op FEV1 is going to be calculated more than 40%, DLCO more than 40%. And if they're marginal, we do exercise studies, and we want to make sure their VO2 max is greater than 15 for a lobectomy. Remember my analogy, if they can walk up 3 flights, they can have a lobectomy. If they walk up 5 flights of stairs without stopping, they can have a pneumonectomy. The treatment involves platinum doublets. You must give a platinum drug plus another if you're going to use chemotherapy. Anybody who has a stage 2 or higher is getting offered drugs. This is no longer a disease of just surgeons. This is a disease medical oncologists should be involved from the beginning. Molecular testing on everybody. That sometimes takes an extra week or 2 to get the results back, but it changes the effectiveness of the drugs that we treat patients with. These patients who are found to have mutations that we have a drug for are going to benefit from that testing. And immunotherapy has revolutionized how we think about lung cancer, especially stage 4 disease. If you have immunotherapy effectively work for you, you have just altered how long those people live. This is a multidisciplinary cancer. It involves all of our efforts together. And if you didn't know that, we have a clinic every Wednesday afternoon where thoracic oncology makes up medical oncology, radiation oncology, interventional pulmonary, and thoracic surgery all see the patients together. Lung nodules are found in a high quantity with lung cancer screening and for other reasons. If they're 8 millimeters or more, use PET scan. If they're less than 8 millimeters, consider using the LungRad system. And remember, these nodules are now accessible, and you should come by and see our new robot. It's pretty cool the way we can get out to peripheral lung nodules. You should know that your patients are at risk for lung cancer if they have smoked, and if they've smoked more than 20 pack years or more, and they're age 50 to age 80, they're going to qualify for lung cancer screening. They have to be a current or former smoker, and we need to be doing this in our patients to determine that they have a nodule before they develop symptoms. That is the only way we're going to change survival of lung cancer. 20% survival, proven, but could be a lot higher based on people who have scans every year, not just 3 years in a row. These are some of the highlights of articles that I have for you, and I'd be happy to answer any questions you guys have about lung cancer, screening, e-cigarettes, or the like.
That's really exciting. I felt like a lot of patients who come to clinic, when you're trying to fit them into all those criteria for lung cancer screening, I think that will help open, like you said, a lot of doors for people to be evaluated.
There are a number of people that fit in the, we call them category B, which is like, what if your patient is 49 years old but has 150 pack years already? Do they not get screened? Well, the answer is insurance is not going to pay for it, but we can still have a conversation with them about smoking cessation and a conversation about, do you want to pay out of pocket to find out if you might have it? We know there's this other category that's growing. Asian female never smokers coming in with a family history of EGFR. What do you do for them? Well, I would offer them screening. Insurance is not going to cover it. But if you knew that you had a risk of developing lung cancer and your parents both had an EGFR positive mutation, I think you would think about doing that screening. So officially, this is what's going to be covered. Because we just changed this number down, Medicare is not going to cover 30, unless you have 30-pack year and age 55 for this year. Sometime during this year, they're going to have to back down to match the U.S. Preventive Services Task Force. So I would recognize these two numbers, 20-pack years, age 50 to age 80, as the numbers to remember, and go ahead and order them that way. We'll deal with it on the other side of the patients who are now in this new category that qualify. We may have to make them pay cash like we used to do, $75 for the screen.